Thank you very much for inviting me and giving me the opportunity in this excellent meeting. My name is Yoneda. I'm a pediatric surgical oncologist and a chair of the surgical committee of the Japan Children's Cancer Group, JCCG. Today, I'm going to talk about surgical strategy in Japanese neuroblastoma clinical trial. Now, as of January in 2023, 124 institutions is participating in the neuroblastoma committee in JCCG called JNBSG. At the beginning, JNBSG classified patients into 3 risk groups according to the previous COG risk classification. Initial 4 JNBSG clinical trials, JNH07, H11, L10, and I10 were enrolled patients as indicated categories. Let me start with low and intermediate risk neuroblastoma. I took this information from the PDQ. Treatment options for low-risk neuroblastoma consisted of 5 options. Surgery followed by observation without with or without biopsy, observation with biopsy, and chemotherapy with or without surgery, radiation therapy. Several studies have shown that the patient with favorable biology and residual disease have excellent outcomes without surgery. Some patients with presumed neuroblastoma have been observed without biopsy. This slide shows treatment options for intermediate neuroblastoma, chemotherapy with or without surgery, surgery and observation in infant, and radiation therapy if needed, mostly the MS tumor. According to the German prospective clinical trial, a total of 93 infants whose tumor were not resectable without high-risk surgery because of age or organ involvement were observed without chemotherapy and excellent outcome. So previous evidences showed complete resection is not always necessary in this group of patients. Tumors sometimes keep being stable or regress without any treatment. Thus, to minimize treatment complications is requested. Since 2010, JNBSG have been employing protocol using IDRF for localized neuroblastoma to minimize surgical complications. In these protocols, when IDRF is present, initial tumor treatment extirpation is recommended. And when IDRF present, a biopsy followed by chemotherapy should be done. Finally, a second-look surgery is performed. In the clinical study for low-risk patients, JNL10, the presence of IDRFs was a key factor in determining whether a patient should undergo surgery or chemotherapy at the times of evaluation. Evaluations were performed at diagnosis after every 3 courses of chemotherapy. This slide shows the evaluation criteria. According to the IDRF, tumor markers, tumor markers, and the MIBG uptake, we determine the next treatment or the end of the treatment. Main results of the JNL10 have already been published in PBC by Professor Yehara in 2019. The outcome of JNL10 was quite well. 3-year overall survival was 100%, and the 3-year progress-free survival was 82.8%. This slide shows the treatment results of the JNL10. 34 patients underwent surgery rather than a biopsy indicated by yellow background. This slide shows the clinical features of 34 patients. IDRFs were present at the time of diagnosis in 6 patients. IDRFs disappeared after neoadjuvant chemotherapy only in 2 of 6 patients. Complete resection was performed in 29 patients. Major surgical complications were observed in 5 patients. In 2011, the INRG published new guidelines for imaging and staging of neuroblastoma. In these new guidelines, the special IDRF definition was mentioned. Even if the tumor is in contact with renal vessels only, this situation should be considered IDRF present, which used to be diagnosed as IDRF absent. According to the new guideline, IDRF results altered from not present to present in 13 patients. So finally, 56% of the patients were indicated as IDRF present according to the new guidelines. Regarding with surgical complications, 2 of 6 patients with IDRF and 3 of 28 patients without IDRF encountered major surgical complications before applying the new guideline, respectively. On the other hand, after the application of the new guideline, 5 of 19 patients with IDRF encountered surgical complications, and all 14 patients without IDRF did not encounter surgical complications. Then, sensitivity for complications increased from 40 to 100%, and the specificity decreased from 86% to 50% after introduction of the new guideline. Therefore, 13 patients would have been treated with chemotherapy instead of primary resection after applying the new guideline. And actually, 10 of 13 patients were safely cured by surgery alone. We also analyzed the treatment results of the 37 patients with abdominal neuroblastoma in the JNL10 according to the relationship between the renal vessels and the tumor. Patients were divided into 3 groups according to the relationship between the renal vessels and the tumor. Group S separated, Group C in contact, and Group E encased. Of 26 patients indicated by orange background who underwent surgery rather than a biopsy, surgical complications were observed in 4 patients, all in Group C, contact. For intermediate risk patients, we conducted JNI-10, a phase 2 efficacy study of IDRF-based surgical decisions and stepwise treatment intensification for patients with intermediate neuroblastoma patient. Protocol paper was published in 2020 by Professor Uehara. This slide shows the study design of JNI-10. Like JNL10, we decided that we made an evaluation every 3 courses of the chemotherapy. JNI-10 is not finished. It is in follow-up period. So I just show surgical complication data only this time. IDRF present cases were more frequently observed in intermediate patients. Major surgical complications were also more frequently observed in intermediate patients. I would like to emphasize that 41% and 59% 41% of low risk and 59% of intermediate risk patients did not undergo resection during the protocol treatment. We are carefully following those patients to find out the necessity of surgical resection in non-high-risk neuroblastoma. This is a summary of low and intermediate risk neuroblastoma. Clearing all IDRF by neoadjuvant chemotherapy is observed in limited number of patients. The new guideline, contact with renal vessels as IDRF, raises the IDRF positive rate in abdominal neuroblastomas. Contact with renal vessels might be a potential surgical risk for abdominal neuroblastoma. Surgical decision based on the new guideline may reduce the risk of renal complications. However, the number of patients receiving additional chemotherapy for residual tumors would probably increase. IDRF present cases and major surgical complications were more frequently observed in intermediate neuroblastomas. Now I'm going to move on high-risk neuroblastoma. Left picture showed that results of my mentor surgeon, high-risk neuroblastoma surgery. He starts his operation at 9 o'clock in the morning and usually finish at 2 or 3 o'clock in the next morning. Actually, viable tumors were confirmed histologically. As you already know, the optimal extent of surgery in high-risk neuroblastoma is still a matter of debate. This slide shows recent major reports about extent of resection in high-risk neuroblastoma. Upper 4 reports, indicated by yellow background, supported the advantage of complete resection or gross total resection on survival, whereas lower 2 studies indicated by green background did not support the advantage of complete resection or gross total resection on survival. JNH07 was a late phase 2 single-armed study. The patient received 5 cycles of induction chemotherapy followed by a high-dose chemo with autologous PBS-CT. Radiation is given to the initial tumor bed. Surgery was recommended to perform after 3 or 4 courses. Professor Hishiki evaluated the surgical treatment in JNH07. There is no correlation between the extent of surgery and the overall survival of the patient. And we could see that nephrectomy does not contribute to improve the overall survival of the patient, encouraging us to leave the kidney intact as possible. It is well known that most of the relapse in high-risk neuroblastoma is observed in distant site. This is the very recent report from INRG about pattern of site of relapse in INSS stage 4 patients. Only 8% of the patient had isolated local relapse. The other hand, 76% and 16% of the patient had a distant only and combined local and distant relapse respectively. So we hypothesized that systemic disease control named time-intensified strategy is important to reduce recurrence rate in high-risk patients. This slide shows possible advantages of time-intensified strategy, avoiding the interruption of systemic chemotherapy by surgery, which might promote acquisition of drug resistance, clonal evolution, and host immune suppression. Therefore, time-intensified chemotherapy with delayed local treatment enables more effective control of systemic disease. From this hypothesis, we started the next clinical trial for high-risk neuroblastoma from 2011. The main concept of JNH11 is the delayed local treatment. In this protocol, all courses of chemotherapy, including myeloablative high-dose chemo, are completed before surgery, surgical resection, and local radiotherapy. This slide shows 3-year OS and PFS in all 64 patients in JNH11. 3-year OS and PFS was 80.7% and 44.4% respectively. Surgery rather than a biopsy was performed in 56 patients. Major surgical complications were observed in 1/4 of the patients. This slide shows Kaplan-Meier estimates of PFS and OS for the next extent of resection. There is no significant differences of PFS and OS according to the extent of resection. Professor Hishiki also made the interim analysis of JNH11. He compared surgical treatment results between JNH07 conventional treatment group and JNH11 delayed local treatment group. Extent of surgery was not significantly different between the two groups. Platelet transfusion was required more frequently in delayed control surgery. Complication rate was not significantly different between the two groups. Not significant, but the frequency of nephrectomy tend to decrease in delayed local surgery. So we concluded that delayed local surgery appears to be a safe and feasible option for high-risk neuroblastoma patients. So finally, I would like to finish by making the following points. I would like to suggest you that systemic disease control should be the first priority, and the surgeries should not interfere with the seamless continuation of multimodal treatment. Please discuss timing and extent of surgery by multidisciplinary team, not only by surgeon. Surgeons should try maximum removal of viable tumor tissue with minimum complications. Please put effort to preserve kidneys for future treatment and the future life of the patient and minimize the interval of chemotherapies. I would like to thank all the patients and families who participated in JNBSG studies. All JNBSG participated institutions and doctors and all members of JNBSG. Thank you very much for your kind attention.